I do emergency medicine and internal medicine. So what that means is that I walk into an emergency department that is full with patients in the hallways, and I also work on the floors, which, if you're admitted to a hospital, that's where you go, where we have healthy patients, people who have been admitted, they were sick, now they're good to go to the next echelon of care, but they're sitting around and waiting, not because they need to wait, but because we're waiting for prior authorization.
Hey, it's Jordan. I am in Flint, Michigan, East Palestine, Ohio, Tumwa, Iowa. Please support the only independent outlet on the ground covering what the corporate media covers up.
This is Ashley with Status Coup News, and John Farina and I are outside covering the federal court case against Luigi Mangione.
So I'm a doctor, I'm an emergency doctor, and it's less about the murder trial and more about, I guess, what the nation has been discussing because of what happened, which is our healthcare system is broken. One of the things that I've been trying to be a proponent of is the New York Health Act, which is a single-payer program for New York State. The way that our health system is set up now hurts people. I think that's what the murder was meant to bring light to, is the fact that the system that we have in place right now, a for-profit healthcare system, is killing people. One of the things that came out recently was there's a RAND report about emergency medicine that showed that one of the things that is kind of destroying our ability to provide emergency care in America is private healthcare. With the No Surprises Act, I'm not sure if you're familiar with what that was. So in 2022, the No Surprises Act was well intended. What it did was it said that if you went to an in-network hospital, but there was maybe an out-of-network anesthesiologist that took care of you, right? That you couldn't get banged by this out-of-network cost, even though you went to a hospital and presumably everything was supposed to be in-network and covered. But that's what was happening to people, which is objectively wrong, right? If you get paid for a service at a certain rate, you should be covered for that rate. There shouldn't be any surprises. So the No Surprises Act.
Which, that sounds very well-intentioned and sounds like it would be a good thing, but I'm gathering that you feel otherwise.
So the nature of these private insurance companies is to deny and to delay, right? And so what they were able to do then, I guess to back it up a little bit, one of the things the No Surprises Act said was that we're removing the patient from the equation, right? It's providers and insurers, which I think is right? That sounds like a good thing, especially with medical debt, bankrupting so many Americans, it makes sense to remove them from that process. They shouldn't be surprised by what they have to pay. So what that then did was it kind of gave the insurance companies a lever that they could pull that said, all right, well, I know that we were going to pay you X amount, a reasonable amount of money to take care of this patient, but if you don't want to be if you don't agree to lower wages or lower prices for that same care, we're just going to make you out of network. And so then what that does is it incentivizes accepting lower amounts of payment for the same service. Otherwise, you get thrown into it being an out-of-network provider. If you're out of network, then you essentially, if you want to deny payment, and I'm like, well, no, we provided you a service, then what you have to do is you have to go to a third-party arbitrator, and then this goes into that whole delay and deny. So I say no, but now you're going to go to a third party to arbitrate that, and then that may take weeks or months. But the emergency department still has to stay open 24/7, 365, and it may not have the luxury of being an NYU. It may not have the luxury of being like a Northwell that has a little bit extra money. A lot of these safety net and rural hospitals, they don't have that backup system. And so now what you're doing is you empower the insurance companies to essentially lowball emergency departments, and it's they're at risk of shutting down. And when an emergency department shuts down, what happens is the patients don't stop being sick. They have to go to other places. We saw that in, I'm a provider in Brooklyn. We saw that when Kingsbrook Jewish shut down, where the patients that were going to Kingsbrook Jewish, they didn't stop being patients. They didn't stop having, your blood pressure issues and diabetes doesn't go away. As soon as your emergency department shuts down, you just have to go seek care at other emergency departments. And so, that's one of the many reasons that I'm out here. But, that system goes away if you have a single payer that's not trying to manipulate the system. If you have a single payer whose job and intention is not to siphon money from a system, and their job and intention is to take good care of patients and empower physicians to take good care of patients without money being the bottom line, then you end up with better care. And the New York Health Act is also projected to save the system. I think it was like some $20 billion. And so if we're looking at rooting out waste, fraud, and abuse from a system, then the waste, fraud, and abuse is being perpetrated by these for-profit insurance companies that are siphoning billions of dollars from Medicare into their Medicare Advantage plans that are for profit, right? That's why we're seeing like all of these healthcare systems saying they're not going to take Medicare Advantage plans anyways. I think recent in the last year there was like a Crane report that said that 37 hospital systems said they're not taking Medicare Advantage plans anymore because it's a bad plan, right? But these for-profit insurance companies, with UnitedHealthcare being like the worst perpetrator, they have the most Medicare Advantage plans, right? Like they're the largest purveyor of providing these kind of like shit plans. And so, that's why I'm here, is because, we should be protesting these plans that are hurting Americans and providing poor care for what we're paying into it. That's why, Americans, for what we pay in, it's like, we have like the most that we pay per person across like developed countries, but with the worst outcomes.
For sure. I mean, that is all excellent. And I think that the framing of, we are trying to supposedly root out waste, fraud, and abuse. This is a key example of that. And I think it's a really important one for people to kind of understand that if we are genuine in trying to do that, here is a really good place to do that. And I think it's also really interesting. I was at the last rally, and a lot of the people there were healthcare providers. They were doctors, they were nurses, they were, people who were in some way involved with patient care. And I think it's really important to note that they are, again, people who are seeing firsthand, like you, the effect that this predatory system is having on patients.
Absolutely. That's why I'm here. Like, I have better things to do on a Friday than show up to a courthouse. But the way that the system is built and the things that I have to go to work and see, like that, it's what's drawing me out here. I don't like it when patients are surprised either. I don't like it when I have to. So I have like dual training. So I do emergency medicine and internal medicine. So what that means is that I walk into an emergency department that is full with patients in the hallways, and I also work on the floors, which, if you're admitted to a hospital, that's where you go, where we have healthy patients, people who have been admitted, they were sick, now they're good to go to the next echelon of care, but they're sitting around and waiting, not because they need to wait, but because we're waiting for prior authorization. And what we saw recently, I think in Blumenthal, he had like a Senate report that showed that they're intentionally using AI to delay these dispositions to acute rehab facilities because it makes them money. But what that does, if you put a stopgap exiting the hospital, is everybody then backs up. And then when you get sick and you have to go to the emergency department for an emergency, now you're in the hallway or now you're in the waiting room instead of a bed. And so these are objective harms that we're seeing that we may not be linking with the insurance companies in the way that everything is set up, but it is a disaster that they have manufactured. The boarding crisis can be linked back to the for-profit insurance companies in the way that they're delaying our ability to discharge patients from the hospital.
For sure. I have my own experience of this relatively recently. I had to go to the emergency room maybe about 6 months ago, and I spent the entire time waiting in the hallway. So I was there for maybe 8 hours and just sat.
That's the thing, is like, it's not uncommon for me to go to the emergency department and I'll see the same guy that I saw there 2 days ago, because he's waiting for a bed upstairs, but he's waiting for a bed upstairs because the bed upstairs is currently being occupied by somebody who may be probably not as healthy as me or you if they're waiting to go to a rehab, but they're ready to go. But the whole process, it requires for you to go from being well to go to a rehab, you have to have rehabs accept you, right? And that means that our doctors have said, we think that you're healthy enough to leave. They have accepted you. You've made your choice. But then we had to wait for prior auth. And I had one patient where it took her 10 days to receive this prior authorization, which is the insurance company's rubber stamping. Like, oh yeah, you know what? The doctor that has seen you every day, we concur, right? But they're not coming to the hospital. They're not with patients day by day. And so all it does is delay care, and it gets you stuck in the emergency department in a hallway bed, as opposed to, I'm sure there were other rooms available that you saw, and I'm sure everybody wants to get the best care that they can. And I don't think that people appreciate that sometimes the best care right now in America is in a hallway bed. Or, if they don't have hallway beds, they may have hallway chairs. If you go to my hospital, we have fold-out chairs. So
I mean, yeah, I saw a lot of that, and as you are a doctor, it must be there must be almost an insulting feeling to have your medical expertise kind of second guessed by an insurance company. So you've said this patient needs XYZ, they need this medication, they need this bed, they need to be admitted, whatever it's going to be, and then to have an insurance company that doesn't have your training, does not have your expertise, come back and say, well, hold on there, we actually don't want that. I mean, that must be so frustrating.
It's frustrating. It's interesting because, you go to med school to learn that somebody needs a CAT scan, right? You go to med school to learn that somebody needs an antibiotic, and you learn all about that antibiotic. But then when you start practicing, it seems silly that you also then have to learn, we're going to get an x-ray before an MRI because otherwise the insurance won't cover it. Right? So you're introducing extraneous costs into the system, not because you think that it's needed. Sometimes, when I'm the way that we learn is we take little tests, practice test questions. Sometimes the practice test question, which is the evidence-based answer, is not what you have to do in real life, because you have to jump through hoops in real life before the insurance company's like, you know what, that's okay.
Yeah, I mean, that is crazy. And as you said, you're adding more costs to the system in the hope, I guess, that they can save a little bit of money.
And I think that's part of the problem, is that the system that they have developed, it's there with the assumption that I'm going to abuse the system, right? That's why they have to rubber stamp every decision I made, as opposed to looking at things at the back end and being okay, where can we maybe root out some of the things that we should investigate? Maybe there's problem providers, but not every provider is a problem provider. But with this whole prior authorization system that delays and denies care for the sake of money, sometimes they don't even have actual people making that decision. It's all AI generated, and they knew that it was inappropriately denying claims, but they did it anyways because it was improving their bottom line. So it's all insane.
Yeah, we recently did a story about AI, I guess taking over patient care in the healthcare system. How do you feel about that, given already your experiences with this?
Oh, it's terrible. It's not. So I think AI has a role. I think recently I heard, which I agree with, AI will not replace doctors, but doctors who use AI will replace doctors. And I think that AI has a powerful role to play in medicine. It has a powerful role in helping me make decisions in more nuanced cases, or kind of when I'm stumped. Not everybody is a textbook, right? People do present atypically or in ways that are sometimes surprising. And I think AI plays a powerful role in kind of helping me identify those kinds of patients. But where it has no role is denying care for people. Because we have physicians at the bedside saying that a patient needs a thing, right? We are competent authorities on emergency medicine, internal medicine. Most recently, I believe it was a breast surgeon who's been trying, very publicly to try to get care for her patients, and then was rerouted to people who weren't even in her specialty. That's not AI, but it's kind of the same concept of them using a kind of an unqualified, unverified tool to try to delay care. And I believe they were using AI also to deny the claims that they thought would be most successfully denied as well, irrespective of what it was for. They're they're probably not going to try to appeal this decision, so let's set up our AI system to deny that, which is, I don't know, it's criminal, especially when you're talking to doctors, nurses, people who have dedicated their lives. For me, I was in training for the last 10 years, just so that I can take care of you for 8 hours in the emergency department, and for them to kind of come across with just something that was developed and really became mainstream over the last few years to make sweeping changes to their decision making. It's insulting.
Absolutely. And, given everything that you've kind of laid out for us, do you think it's surprising that something like this has now happened? As far as the Luigi Mangione's alleged murder of the UnitedHealthcare CEO, Brian Thompson?
I don't think it's surprising. I don't condone murder. I'm in a healing field. But, I mean, I also see lots of people who have hurt other people in the emergency department, where I take care of patients. Like, we have gun violence and interpersonal violence. So it's not surprising that, Americans do what Americans do when they feel like they're cornered, and that's that they hurt other people. But this is a byproduct of our insurance companies hurting people and people feeling cornered and feeling like they had nowhere else to go, no other options. And here we are standing outside of a courthouse.